All right, we have reached Chapter 15, Psychological Disorders. We'll be breaking up this chapter into two different sections. So today we're doing 1 through 3, and then on Thursday we'll finish up sections 4 and 5. So let's go ahead and get started talking about psych disorders. All right, so there are four major questions surrounding the study of psychological disorders. And the first one is, how do we define psychological disorders? How should we define them? How do we understand disorders? How do underlying biological factors contribute to the disorder? How do troubling environments influence our well-being? How do the effects of nature and nurture interact, essentially? How should we classify psychological disorders, and can we do so in a way that allows us to help people without stigmatizing or labeling them as having some kind of problem or disorder? What do we know about the rates of psychological disorders? How frequently do they occur? How many people have them? Who's vulnerable? And when in the course of their life are they vulnerable? So we will talk about all of these questions as we get through Chapter 15. So how would we define a psychological disorder? Well, a psychological disorder is marked by a clinically significant disturbance in an individual's cognition, emotional regulation, or behavior. So it can be any of these things or a combination of them. But a clinically significant disturbance is pretty vague and subjective. So what we mean by that is that these thoughts, emotions, and behaviors are dysfunctional and maladaptive, and they interfere with our day-to-day life. That's the most important part, is that it interferes with your day-to-day life. This is not something that just pops up out of nowhere, bothers you for a minute, and then goes away. It's something that's going to persist every day and affect you. Homosexuality used to be classified as a psychological disorder in the DSM up until December 10th, 1973, and that's when it was removed. So not until the early 70s did we actually get that removed from the DSM. But what people thought was, because homosexuality occurs frequently with psychological disorders, that homosexuality leads to psychological disorders. That's not the case. So here's what I want you to write down under number 3 in section A. Being homosexual does not increase the risk of developing a psychological disorder. Being ostracized is what increases the risk. And ostracism just means being pushed out or left out of a group. Kind of being isolated, socially isolated by others. So again, being homosexual does not increase the risk of developing a psychological disorder, but being ostracized is what increases that risk. And of course, people who have a different sexual or gender identity are frequently ostracized, which is why we see higher rates of mental illness among people who are in the LGBT community, not because they're LGBT, but because of the way they are treated for being LGBT. So, like I said, the stigma and stresses that people who are LGBT experience can increase the risk of mental health problems. And in other words, ostracism is what increases that risk. And the LGBT community is one group that has been marginalized and ostracized throughout history. All right. In the Middle Ages, people actually believed that it was the devil that made people behave in disordered ways. And so when people were considered mad, insane, at this time, they were sometimes caged or given therapies like genital mutilation, beatings, removal of their teeth or lengths of their intestines, or transfusions of animal blood. And anything that they would do, like removing teeth or lengths of intestines or giving transfusions of blood, that's where they thought the demon was located. So if they thought the demon was located in the teeth or in your intestines or in your blood, then that's the type of stuff that they would do to remedy it. Of course, it didn't work, right? Reformers suggested that madness was not demonic possession, but it was a sickness of the mind caused by severe stress and inhumane conditions. And so they said that we actually needed a moral treatment. We needed to boost patients' spirits by unchaining them and talking with them. So we tried to replace this kind of brutality with a gentleness, replace isolation with activity and socialization, and replace filth with clean air and sunshine. And that did result in a lot of improvement for people. The medical model says that psychological disorders have a cause, an identifiable physical cause. and we're able to diagnose, treat, and often cure psychological disorders. That's what the medical model suggests. So previously we thought it was demonic possession, but now we're saying, no, there's a physical cause to psychological disorders, and we can find that cause. We can diagnose it, we can treat it, and in most cases, we can cure it too. And so this actually formed as a response to new information regarding syphilis. They found that syphilis infected the brain and distorted the mind, which resulted in people acting as if they were experiencing psychosis, but it was because of the syphilis that was infecting their brain. So people at that point began to search for physical causes of other mental disorders and treatments that would cure them. So this kind of opened the door to the realization that mental disorders have causes that you can identify. Then the mental health movement states that a mental illness needs to be diagnosed on the basis of its symptoms, and it has to be treated through therapy, which might include time in a psychiatric hospital depending on the severity of the situation. And through this perspective, we've made a lot of discoveries about genetically influenced abnormalities in brain structure and biochemistry that can lead to the development of psychological disorders. So the medical model has been very helpful in getting rid of those old bad ways of dealing with psychological disorders, and instead coming towards methods that actually improve the situation for the person and their quality of life. Okay, main points of this section, the biopsychosocial approach. As individuals, we differ in the amount of stress we experience and our ways of coping. So some people are more prone to developing mental illness in response to stress compared to others. Just depends on the way that you cope. There are 2 disorders that occur worldwide, and they are major depressive disorder and schizophrenia. We have not found that any other disorders occur worldwide, so that's kind of interesting. Like bipolar is not worldwide, OCD is not worldwide, even anxiety is not listed as being worldwide. But it might just be that they have a different name for it, or they classify it differently. Latin America claims the disorder susto, which is the condition marked by severe anxiety, restlessness, and a fear of black magic. So some other countries just kind of have their own ideas of what is a mental disorder that we don't have. We certainly don't have a mental disorder that we're aware of that involves a fear of black magic, right? In the Japanese culture, there's one that involves social anxiety about appearance with a readiness to blush and a fear of eye contact. Eating disorders, anorexia, and bulimia occur mostly in food-abundant Western cultures. We will talk about eating disorders at the end of this whole chapter, so not in this video, but in the next one. But that's kind of interesting that eating disorders actually occur where food is most abundant, not where it's scarce, because in countries where it's scarce, well, now we're just trying to satisfy our basic needs of getting the nutrition that we need to survive. So they aren't really concerned with the way they look, because they're more concerned with the physiological need of needing to eat, needing to survive. Disordered aggression has different explanations in different cultures. So in Malaysia, they have a word, amok, that describes a sudden outburst of violent behavior. It comes from sort of the phrase running amok, right? Disorders reflect genetic predispositions and psychological states. Physiological states, inner psychological dynamics, and social and cultural circumstances. So there's the bio, the psycho, and the social parts. The vulnerability stress model says that individual characteristics combine with the environment, nature and nurture, right, to increase or decrease the likelihood of developing a psychological disorder. And this is supported by research on epigenetics. Epigenetics, as we've said before, is the study of environmental influences on gene expression. Okay. So classifying and labeling disorders. Classification creates order, right? And so in psychology, classification orders and describes symptoms. In psychiatry and psychology, classification also aims to predict a disorder's future course, suggest appropriate treatment, and prompt research into the causes of the disorder. And then the DSM-5 is the American Psychiatric Association's Diagnostic and Statistical Manual of Mental Disorders, and we're in the 5th edition now. and that is a widely used system for classifying psychological disorders. It's considered to be sort of the central guide for the APA in classifying psychological disorders. So if you go through training to become a psychologist, you will have to know the DSM-5 in and out, or the DSM-6, 7, 8, wherever we're at by that point. In the newest edition, autism and Asperger's syndrome were actually combined and placed together under the label autism spectrum disorder, and mental retardation has now been totally thrown out, and we've renamed it intellectual disability. So this is why we have more than one version of the DSM, because we make these little alterations like this throughout to put things together or further differentiate one thing into multiple things, stuff like that, renaming things that become socially inappropriate to say, right? And in real-world tests or field trials that assess the reliability of the DSM-5 categories, some diagnoses have been very reliable, while others were not. And we are going to talk about clinician agreement. I think that actually comes next. Indeed it does. Clinician agreement on post-traumatic stress disorder and autism spectrum disorder was near 70%, meaning that if one psychologist or psychiatrist diagnosed someone with one of these disorders, post-traumatic stress or autism, there was a 70% chance that another mental health worker would independently give the same diagnosis. But for antisocial personality disorder and generalized anxiety disorder, agreement was at 20%. So here's the thing. When you're talking to someone who does have like autism spectrum disorder, those symptoms are very obvious a lot of the time, right? And so clinician agreement is going to be higher with symptoms that are very obvious. But with other disorders, antisocial personality, generalized anxiety disorder, you can't really see those symptoms unless someone is experiencing like an anxious outburst or something like that while you're talking to them, right? And so for symptoms that people just tell you that they have, but you can't observe them yourself, those are way harder to get clinicians to actually agree on a diagnosis when it comes to those types of things. And then we have ADHD, and that's actually no longer in the DSM now, but when this book was written, it still was. So ADHD is a psychological disorder marked by extreme inattention and or hyperactivity and impulsivity. I'm sure that we've all heard of this one before. But for those who experience challenging symptoms, diagnoses and treatment can be a relief, and they can bring improved functioning. But critics say that the DSM's criteria are now too broad, and they can turn normal childish rambunctiousness into a disorder. So, if your child is just running around and they're really, hyper because they're in a playground or they're with their friends or whatever, the situation is affecting the way that they're behaving, and so they're more hyper, than usual, and you get concerned that this is an ADHD issue, all of a sudden you're turning normal behavior into something that's disordered. And that's what critics worry about, that people, parents are going to come in and say, my kid never pays attention, they don't listen, they're too hyper, and the clinician is going to just assume that your child has ADHD when in fact they're just a normal, energetic, rambunctious child. So that's kind of where we run into some disagreement and some issues. Okay, do psychological disorders predict violent behavior? What I want you to write down, number one, for this question is the mentally ill are way more likely to be victims of violent crime than to commit violent crimes. The mentally ill are way more likely to be victims of violent crime than to commit violent crimes. That is very important. Very, very important. People are always scared of the mentally ill, and there's really not a good reason to be. They're not violent for the most part. We'll talk about some exceptions in just a second. So, do disorders actually increase the risk of violence? Can clinicians predict who's likely to be violent? No, unfortunately not. Most violent criminals are not mentally ill, and most mentally ill people are not violent. Clinical prediction of violence is unreliable. It's not consistent. The few people with disorders who commit violent acts tend to be either those who experience threatening delusions and hallucinated voices that command them to act, or they've suffered some kind of financial crisis or lost relationship, or they abuse substances. So when we see this point about delusions and hallucinations, that really is pointing to schizophrenia. So the only psychological disorder that's really related to an increase in violence is schizophrenia sometimes. Again, most schizophrenics are not violent, but some of them do experience delusions or hallucinations that sort of command them to do violent things. And so that they can be violent. But again, most schizophrenics do not experience those kinds of delusions and hallucinations in the first place, and so they're not violent. This is the point I had you write down. People with disorders are more likely to be victims than perpetrators of violent crime. And then there are better predictors of violence than mental disorders, and those would be the use of alcohol or drugs, previous violence, so that's kind of a social cognitive idea, the fact that previous behavior predicts future behavior, and then gun availability as well. A common controversy is, should mentally ill people be held legally responsible for their actions? If so, under what circumstances? Is it better to send the mentally ill to hospitals or to prison? One thing I want to mention is the number one provider of mental health care in the state of Texas is the prison system. That's right. The number one mental health care provider in Texas is the prison system. Yikes. That's a big issue, I think. But in any case, that question of should they be held legally responsible for their actions, that kind of falls under the insanity claim that we have. Most people don't use the insanity claim. When they do, it's rarely successful. But if someone truly has a debilitating mental illness, we certainly should not be throwing them in prison. They need to be going to some kind of hospital or other recovery treatment center. Okay, let's talk about some rates. So the World Health Organization estimated that the number of mental disorders in the prior year in 28 countries. So the lowest rate was in Nigeria at 6%. The highest rate was in the U.S. Go USA, right? Number one. About 28% of people. So that's about a third. It's about a third. That means that between you and the person sitting to your left and to your right in a class, one of you is bound to have some kind of psychological disorder. Crazy, right? Immigrants to the United States from Mexico, Africa, and Asia have averaged better mental health than U.S.-born citizens with the same ethnic heritage. That's kind of interesting. The immigrant paradox refers to the phenomenon that compared with Mexican Americans born in the U.S., Mexican Americans who have recently immigrated are less at risk for mental disorders. So if you were born in the U.S., you are more at risk for a mental disorder than if you immigrated to the U.S. The U.S. National Institute of Mental Health has estimated that about 1 in 5 adult Americans currently have some kind of mental, behavioral, or emotional disorder. And that excludes developmental disorders like chromosomal abnormalities, Down syndrome, stuff like that, things that you're born with. And then substance use disorders are also not counted. 1 in 5 currently has one of these disorders or has had one in the past year. What increases vulnerability? One predictor of mental disorders crosses ethnic and gender lines, and that predictor is poverty. Poverty predicts the development of mental health disorders. The incidence of serious psychological disorders is 2.5 times higher among those who live below the poverty line. And so the question becomes, does poverty cause disorders, or do disorders lead to a life of poverty? It's that cause and effect, direction of correlation question, classic. The answer is a bit of both, actually. So schizophrenia understandably leads to poverty, right? Because you don't really act normal, people don't want to socialize with you, who wants to offer you a job when you're acting crazy all the time, right? But the stresses and the demoralization of poverty can also lead to the development of disorders, especially depression in women and substance use disorder in men. In one study, children of poverty exhibit more deviant and aggressive behaviors, but after 4 years, if they had been moved above the poverty line, they had a 40% decrease in behavior problems. At what times of life do disorders strike? Early adulthood. And the most typical range for developing a psychological disorder is between 18 and 25, early adulthood. Over 75% of the sample experienced their first symptoms by age 24. Antisocial personality disorder and phobias are the earliest to appear at about 8 and 10 years old. Alcohol use disorder, obsessive compulsive disorder, bipolar disorder, and schizophrenia begin a little bit later, around age 20. And then major depressive disorder hits the latest at about 25. But kind of your golden range for experiencing your first symptoms of any psychological disorder is 18 to 22. So I just turned 22, so I think I'm in the clear. Okay, second half. Anxiety disorders. These are psychological disorders characterized by distressing, persistent anxiety or maladaptive behaviors that reduce anxiety. That second part, maladaptive behaviors that reduce anxiety, speaks to obsessive compulsive disorder, which we'll come back to. So let's start out with the types of anxiety disorders. For generalized anxiety disorder, this person is continually tense. They experience tenseness in their muscles all the time. They're continually tense, apprehensive, and in a state of autonomic nervous system arousal. So specifically sympathetic nervous system arousal, right? Unexplainably and continually tense and uneasy. Their heart is beating, their respiratory rate is high. Sympathetic nervous system is really aroused almost all of the time for generalized anxiety disorder patients. So this is marked by excessive and uncontrollable worry that persists for 6 months or more. People with this condition, 2/3 of them are women, worry continually and are often jittery, agitated, and sleep deprived. And again, that kind of really goes back to that sympathetic nervous system arousal. Jittery, agitated, sleep deprived, because your body's constantly aroused. It's not calming down. It's not resting and digesting with that parasympathetic nervous system activity like it should be. Now, it doesn't mean that people with generalized anxiety have a totally useless parasympathetic nervous system. No, certainly it works, but their sympathetic nervous system is much more active, much more often than the parasympathetic nervous system. The person usually cannot identify and therefore cannot relieve or avoid the anxiety that they feel. So we often call this free-floating anxiety because we cannot identify the cause of the anxiety. Panic disorder is an anxiety disorder where you get these unpredictable, spontaneous, minutes-long episodes of intense dread where a person experiences terror and can have things like chest pain, choking, other frightening sensations, and it's often followed by worry or more anxiety over it happening again. So some symptoms: irregular heartbeat, chest pains, shortness of breath, choking, trembling, or dizziness. When people are having a panic attack, they often think that they're having a heart attack. They're not, but because so much of those symptoms comes from sort of the respiratory and cardiac system, it feels that way. There's a lot of sort of buildup of tension and pressure in the chest that makes you feel like something is very wrong in that area. Only 3% of people suffer from panic disorder, but their attacks are recurrent. They keep happening over and over. People who have panic disorder don't have just one panic attack, they have multiple. But we can't predict when these attacks are going to occur, And then a phobia is an anxiety disorder marked by a persistent, irrational fear and avoidance of a specific object, activity, or situation. Specific phobias can be about animals, insects, I definitely have that one, heights, blood, or close spaces, claustrophobia, right? And notice how these things really end with phobia: claustrophobia, agoraphobia, arachnophobia, right? And so to cope with this, many people just avoid the triggers that arouse their fear if they can. You can't really avoid insects, they just pop up, right? But they manage to live with their phobia, while others are totally incapacitated by their efforts to avoid the feared situation. So again, this is just a difference in the way people cope with things. But here's what I want you to write down. And this is how to tell the difference between each of these. So for generalized anxiety disorder, this is constant anxiety or tension, and we cannot identify the cause. Constant anxiety or tension, and we cannot identify the cause. For panic disorder, this occurs spontaneously and then goes away within minutes. And we can usually identify the cause. We can usually figure out what caused it. But that's kind of a hit or miss, 50-50. So again, with generalized anxiety, we can never identify the cause. With panic disorder, we can sometimes identify it. But with phobias, we can always identify the cause because it's something specific that we're afraid of, right? So with phobias, this occurs in the presence of a particular stimulus, and we can always identify the cause. So again, generalized anxiety, constant anxiety and tension, cannot identify the cause. Panic disorder occurs spontaneously and lasts for a few minutes. We can usually identify this cause, or at least sometimes. And phobias occur in the presence of a particular stimulus, and we can always identify the cause of phobia-related anxiety. Okay, so obsessive compulsive disorder is actually a type of anxiety disorder. Don't know if you knew that. But obsessive compulsive is characterized by unwanted repetitive thoughts or actions or both. So what I want you to write down for this one is this. Obsessions are repetitive thoughts. Compulsions are repetitive behaviors. Obsessions, repetitive thoughts. Compulsions, repetitive behaviors. And so if someone has OCD, there's a lot of things that that can be classified as OCD that you might not think are that way. So we often think of OCD as, well, we overuse this term casually. Oh, I'm so OCD, and we really just mean that to say that, you know, we're perfectionist or we need things to be organized, something like that. But really what OCD means is that you have these obsessions and these compulsions. So I think I have some examples in here. The line between normal behaviors and disordered behaviors are when the behaviors persistently interfere with day-to-day living. Remember, this is that day-to-day living component. So like double checking that you lock the door is normal, checking 10 times is not. So going off of that example, the obsession would be, oh my gosh, did I lock the door? Did I lock the door? I can't remember. If I'm thinking, you know, did I turn around and lock the door? I don't know. Like, that's your obsession, is that persistent, repetitive thought. Did I lock the door? Oh my gosh, did I lock the door? Oh my gosh, did I lock the door? Right? And the compulsion is having to actually drive back home and check that you locked the door. Or as you're leaving, you know, jiggling the door handle 10 times to make sure that it's locked. That's your compulsion, your repetitive action, right? So although people know that their anxiety-fueled obsessive thoughts are irrational, these thoughts can become so haunting and the compulsive rituals are so senselessly time-consuming that effective functioning becomes impossible for a person living with OCD that is this severe. Some other OCD-related disorders, hoarding disorder. So the obsession is, I need to keep this, I might need it, or I need to go and gather more things to have in my home, I might need them. And the compulsion is actually retaining these things or going out and getting more clutter and bringing it home. Body dysmorphic disorder. So the obsession, oh my gosh, I'm so concerned with the way my body looks. I think about it all the time. And then the compulsion would be whatever you're doing to solve that. That could be an eating disorder, for example. Trichotillomania is hair pulling. So the obsession is just, I need to pull my hair. I just feel the need to pull my hair out. The compulsion is actually grabbing your hair, ripping it out of your skull. And then excoriation disorder is excessive skin picking. So this goes beyond people who just like pick scabs or something like that. But this is just like you feel the constant need to be scratching, picking, peeling at your skin. So the obsession is the thought, I really want to pull at my skin. I really want to, pick it. And the compulsion is actually excessively picking at your skin. Okay. Post-traumatic stress disorder. So this is characterized by haunting memories, nightmares, social withdrawal, jumpy anxiety, a numbness of feeling, and also insomnia that lingers for 4 weeks or more after a traumatic experience. And that's really key, that after a traumatic experience line, because you can't have PTSD, post-traumatic stress disorder, if you didn't actually experience something traumatic. So veterans, as well as survivors of accidents, disasters, violence, and sexual assaults, often have PTSD at higher rates than other people. Typical symptoms include recurring haunting memories and nightmares, laser-focused attention to possible threats. We call that hypervigilance. This is a type of anxiety too. Social withdrawal, jumpy anxiety, and trouble sleeping. But why is it that 5 to 10% of people develop PTSD after a traumatic event, but others don't? 95 or 90 to 95% of people don't. Why? Well, the higher the distress, such as the level of torture that people suffered, the greater the risk for post-traumatic symptoms. So the more distress, the more risk. But some people just might have more sensitive emotion processing limbic systems that floods their bodies with stress hormones compared to other people who just kind of let things roll off their back. Women are twice as likely as men to experience PTSD. So again, that might have to do with that emotion processing limbic system. We know that women tend to be more emotionally reactive than men. Okay, so some kind of modern perspectives on anxiety. The first perspective is conditioning. So this perspective says through classical conditioning, our fear responses become linked with what used to be a neutral object in an event and then became a threatening one. So anxious or traumatized people learn to associate their anxiety with certain cues. This is basically how phobias develop, if you think about it. There's kind of no reason to fear a spider until you've been bitten by one. And now we associate spider with the painful bite that you get, and now we are anxious about that previously neutral object, the spider, which is now threatening to us. Anxiety or anxiety-related disorders are more likely to develop when bad events happen unpredictably and uncontrollably. So this really just speaks to the fact that anxiety has a lot to do with feeling powerless or like you don't have control over things. And even a single painful and frightening event can trigger a full-blown phobia due to stimulus generalization and reinforcement. Stimulus generalization occurs when a person experiences a fearful event and later develops a fear of similar events. So you got bit by a spider, and now we're afraid of absolutely anything that crawls, right? Reinforcement, anything that enables us to avoid or escape a feared situation, and it helps to maintain learned fears and anxieties. So, people who are OCD, once they do the action, they feel such a release in that anxiety. So, when you're obsessively thinking, I want to pull my hair out, I need to pull my hair out, oh my gosh, I have to. When you actually do it, even though that doesn't seem like it's something that should be satisfying for someone with OCD, that relieves all of that tension and anxiety, which is why they keep doing it, because it's reinforcing them. We're taking away something bad, right? So this is negative reinforcement. We're taking away something bad, that annoying obsession, I can't get this out of my head. We're taking that away, and instead we're replacing it with comfort. And so that's how we can reinforce the way that people cope with phobias. Cognition. So the cognition perspective says observational learning is a big factor in anxiety. We learn most of our own fears by observing other people. And people with anxiety disorders tend to be hypervigilant, meaning that they attend more to threatening stimuli. So they are more attuned to noticing threats than other people. They also more frequently interpret unclear stimuli as being threatening, and they more often remember threatening events. And then the biological perspective has a few kind of facets to it. So first, genes. There's a genetic component to anxiety. We found that twins who are raised apart sometimes develop the same phobias, and if one twin has an anxiety disorder, the other is at risk to develop one. There are also 17 gene variations associated with typical anxiety disorder symptoms, and among those with PTSD, childhood abuse leaves epigenetic marks. So an epigenetic mark is when something within your actual genetic code changes in response to the environment. And so when people are abused as children, this can actually change a gene within them that makes them more likely to develop anxiety or PTSD. When it comes to the brain, traumatic fear learning experiences can leave tracks in the brain that we call fear circuits, and those are going to be in the amygdala. Psychological anxiety disorders can express themselves biologically as over-arousal of brain areas involved in impulse control and habitual behaviors. And the anterior cingulate cortex is likely to be hyperactive in people with OCD. So sometimes we don't even need to know about someone's symptoms in order to diagnose them. If we just take a really good brain scan, you can actually sometimes identify these disorders solely off of that. And then natural selection. So we're biologically prepared to fear threats that were faced by our ancestors, right? Just as phobias focus on dangers faced by our ancestors, compulsions typically exaggerate behaviors that contributed to our ancestors' survival. So healthy grooming becomes a disordered behavior of excessive hand washing, right? Hand washing is a good thing, but when you wash your hands, 150 times a day and your skin is peeling and cracking and bleeding, well, now this is no longer healthy, right? This is disordered behavior. All right. So you're definitely going to want to know the difference between major depressive disorder and persistent depressive disorder. So major depressive is a disorder where someone experiences, in the absence of drugs or a medical condition, 2 or more weeks of significantly depressed moods, feelings of worthlessness, and diminished interest or pleasure in most activities. So you have to have at least 5 signs of depression that last 2 or more weeks to be diagnosed with major depressive. And those signs are depressed mood most of the time, dramatically reduced interest or enjoyment in most activities most of the time, significant challenges regulating appetite and weight, significant challenges regulating sleep, physical agitation or lethargy, feeling worthless, feeling unwarranted guilt, problems in thinking, concentrating or making decisions, and thinking repetitively of death and suicide. Whereas persistent depressive disorder is similar to major depressive, but is less severe, and the symptoms actually last longer. So adults who are diagnosed with persistent depressive disorder have experienced a mildly depressed mood more often than not for 2 years or more, and they display at least 2 or more of these symptoms. Difficulty with decision-making and concentration, feeling hopeless, poor self-esteem, reduced energy levels, problems regulating sleep, and problems regulating appetite. So here's what I want you to write down on your worksheet. Major depressive is 5 or more symptoms that last 2 or more weeks. 5 or more symptoms that last 2 or more weeks. And persistent depressive disorder is 2 or more symptoms that last 2 or more years. So for major depressive, 2 or more weeks. Persistent depressive, 2 or more years. So understand that major depressive has more severe symptoms, but they last for a shorter amount of time, whereas persistent depressive has less severe symptoms that last for a long time. Okay. And then bipolar disorder is where we alternate between the hopelessness and lethargy of depression and then the overexcited state of mania. Let's talk about mania. Mania is this hyperactive, wildly optimistic state in which people make dangerously poor decisions a lot of the time. So mania is sort of this, if you're manic, it's almost like you're on crack, It's like you are just so impulsive and you just want to do whatever you want to do. We're not thinking about the consequences at all. We are just following totally our impulses, right? And so when people are manic, they require very little sleep. Their positive emotions persist abnormally, so they're really, really optimistic, and this can lead to risky behavior, like inhibited sexual activity, overspending money. That's a really common one. Someone who's manic will just go buy a car, even if they don't have the money for it. They'll go take out a loan, they'll go buy a car because that's what they want to do right now, So mania is really sort of the dangerous side of bipolar. The depressive side is not dangerous to others. It's only, I suppose, dangerous to yourself. In milder forms, mania's energy and flood of ideas can fuel creativity. So this is why there are so many actors, producers, writers, directors that have bipolar disorder, because it fuels creativity. Mania fuels creativity. And this is also a big reason why people who are really creative and also bipolar do not want to take their medications, because the medicine kind of numbs this experience and puts them back into like their average, typical state. And so they don't want to take these meds because all of a sudden they're not as creative as they usually are when they're manic, right? There are clusters of genes associated with high creativity, and those increase the likelihood of having bipolar disorder. And there are risk factors for developing bipolar disorder that predict greater creativity. So these are associated with one another, bipolar and creativity. Those who rely on precision and logic, like architects, designers, and journalists, suffer bipolar disorder less often than those who rely on emotional expression and vivid imagery, like composers, artists, poets, novelists, and entertainers. Bipolar disorder affects just as many men as women, so we have about equal rates. Americans are twice as likely as people of other countries to develop bipolar disorder. And the new DSM-5 classifications have begun to reduce the number of child and adolescent bipolar diagnoses. So now some of those who are persistently irritable and have frequent and recurring behavior outbursts are actually diagnosed with disruptive mood dysregulation disorder instead of bipolar. There are certain facts that every theory of depression has to explain. So you have to explain why behavioral and cognitive changes accompany depression. We have to explain why depression is widespread. We see it in every country in the whole world. We have to explain why women's risk of major depressive disorder is nearly double the risk of men. Most major depressive episodes self-terminate. Why does that happen? Why do stressful events related to work, marriage, and close relationships often precede or come before depression? Compared to past generations, depression strikes earlier now, and it affects more people, with the highest rates among young adults in developed countries. So we have to explain why that trend has occurred. Okay, and now we're finally in the last part here. There's a lot of kind of just cataloging, so just kind of write down some main points for these sections. So, biological perspective, let's start with genetic influences. Depressive disorders and bipolar disorders run in families, so that is pretty clear evidence for a genetic link. Heritability of major depressive disorder is 40%. Linkage analysis is when geneticists find families in which the disorder appears across several generations, and they search for differences among the affected and the unaffected family members. So we're looking for why some people in this family developed the disorder, but others did not. What are the differences that put these people in these two different categories of life experience? Next one is the depressed brain. So we can use scanning devices to monitor the brain during depressive and manic states, and they are very, very different images, which is why it's pretty easy to tell the difference between depression and bipolar by putting someone in a brain scan, because in a depressive state, they're going to look the same, but as soon as we hit mania in the bipolar person, their brain's going to look way different under a scan than a depressive person, because someone who's depressed has very low brain activity, but someone who is manic has extremely high brain activity. Almost every part of their brain is lighting up. Depression can cause the brain's reward centers to become less active, so you actually feel less satisfied by accomplishing goals, which is part of the reason that people feel so unmotivated to do anything when depressed, because they don't even get the reward, that feeling of being rewarded when they do something. People with bipolar disorder have been found to have decreased white matter in their brain and enlarged ventricles. Norepinephrine is scarce during depression and overabundant during mania, and then serotonin is also scarce or inactive during depression. Nutritional effects. People who eat a heart-healthy Mediterranean diet, which is heavy on vegetables, fish, and olive oil, have a comparatively low risk of developing heart disease, stroke, late life cognitive decline, and depression, because all of these things are associated with inflammation. And then excessive alcohol use correlates with depression as well, partly because depression can increase alcohol use, but mostly because alcohol misuse leads to depression. Last one. Okay. Social cognitive perspective. says that diet, drugs, stress, and other environmental influences lay down epigenetic marks that can turn genes on or off. So the environment that we live in can change our genetic code. And the social cognitive perspective explores how people's assumptions and expectations influence what they perceive. So for example, depressed people often view life through this dark lens of low self-esteem, right? Expecting the worst, depressed people magnify bad experiences and minimize good ones with self-defeating beliefs and a negative explanatory style. An explanatory style is sort of just who or what people blame for their struggles. And we'll actually talk a little bit more about that later. Negative thoughts, negative moods, and gender. Women respond more strongly to stress than men, which might explain why they're twice as likely to develop depression. And women are also more likely to ruminate and overthink. Rumination is just compulsive fretting, so just thinking a lot about this thing that's bothering you, overthinking your problems and their causes. And this can distract us, increase our negative emotions, and disrupt our daily activities. Here we are back at explanatory style. Explanatory style is a predictor of depression. Depressed people tend to view events as stable, global, and internal. So there are these three scales of explanatory style. There's stable versus unstable, global versus specific, and internal versus external. So if stable is, this is going to last forever. Unstable is seeing it as, this will go away eventually. It might suck that I feel this way right now, but eventually I will feel better. So it's kind of like optimism a little bit. And then global versus specific. So global says, this is going to affect everything I ever do. And specific says, yeah, well, this is annoying, but it's not going to affect the rest of my life. It doesn't affect everything in my life. And then internal versus external. It's all my fault, internal, or it's not my fault. Something else caused this, would be external. And then depression's vicious cycle. Depression is both a cause and an effect of stressful experiences. Stressful experiences interpreted through a ruminating and pessimistic explanatory style create a hopeless, depressed state that hampers the way a person thinks and acts, and then it fuels further stressful experiences. So this is really just kind of like a positive feedback loop where something bad happens and then it affects the way that you think about it and how you're constantly ruminating on it. And constant rumination makes you feel worse, and then you ruminate on it more, it makes you feel even worse, right? And it just sort of cascades into this pit of depression, which is the vicious cycle of depression.